and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet, as I adjust the camera here. And we are streaming live from downtown Richland, Washington. And we are super excited to have John Oertle on our podcast today. He is with Solidarity HealthShare. And if you follow us enough, we have talked over and over and shouted out about how health shares are so important when it comes to us having medical freedom and just getting out of the insurance care model, because traditional insurance is not here to help us get healthier or for our benefit. They're for their benefit only, for profit. So we're so glad to see health shares growing. And I really want to thank Solidarity for sponsoring Medical Freedom Northwest, which we had a few weeks ago. One-day conference on medical freedom in Spokane, Washington. Mark your calendar for May 2nd next year in Spokane, same place as we have our fourth conference in Medical Freedom Northwest. So, John Oertle, welcome to our show.
Hey, great to be here, guys.
Yeah, so tell us a little bit about your history and then how you got into Solidarity and this health sharing company.
Yeah, so I'm a naturopathic doctor. I've been, so I always say that I got into medicine because I was diagnosed, I was a patient myself, and I was diagnosed with type 1 diabetes at 10 years old, which is an autoimmune condition where your immune system attacks the beta cells of the pancreas. It was after actually I had a negative reaction to a vaccine. It was the DTP vaccine back in the day. They've made it a little safer, but still has side effects of potentially causing autoimmune type 1 diabetes. And so this is what actually caused me to have an adverse reaction, starting to be able to attack my beta cells, and got involved in the actual healthcare system because I started going in and being thrown into the local Phoenix Children's Hospital, and started to be able to meet with endocrinologists and understanding the body. I loved my body. I loved the science. I loved the physiology of medicine. And so this is really what drove me down this pathway of prevention, wellness, metabolic health, and even from a young age, just learning about, well, if I eat this and do this and take this med or take this supplement, and then it does this, right? So I can see this direct causation reaction, even from even I remember this from a young, schoolboy. And so medicine captivated my mind. And then I remember going into an adult endocrinologist office when I came into, my adult endocrinologist office when I came into college. And, I'm sitting there as a young 18-year-old kid, and I'm in an office with patients that are, have amputees, that are amputated, that are blind, being led around. I'm packed in like sardines, I'm this young kid. And I just remembered looking around, it still seems so clear in my mind, just looking around saying, I don't want to end up like these guys. I've been trying to be able to protect myself from doing this, and I don't want to end up like these. And a little bit later, again, well, actually, quite a little bit later, with waiting in the waiting room so long, and then meeting with the endocrinologist, and I meet with him, and he actually is like, John, you're doing great. Keep up the good work. And I'm like, okay, well, that's great, doc. Is there anything more? Is there any more data, technology? What's the latest? I'm here. I want to make most use of my time. I'm grateful that you think I'm doing well. I'm grateful that I'm healthy. My blood work looks good. But I do want to be able to make sure that I'm doing everything I can possibly do to be able to be well and prevent this disease from the future. Is there any new technology, devices? What's going on? Well, and he goes, actually, yeah, there could be something that you can do. He pulls out his script pad and he writes me a prescription of lisinopril. Okay. And I'm like, okay, so this is, and lisinopril is a medication that it's a ACE inhibitor, and it lowers blood pressure. And I even remember, I'm like, doc, what is this? He goes, oh, this is a blood pressure lowering medication. I said, well, doc, did I have high blood pressure? You didn't mention this. Do I have high blood pressure? He goes, no, but he goes, if you take this, it shows that it'll prevent the kidneys from having your going into renal failure. And so just take this, and this is your preventative measure. And I just remembered leaving that office, and I just started doing a lot of research at that time. Started asking people about this, and I'm like, I don't know if I need to take this. And as it would have it, I had a good friend who was a naturopathic doctor, And he actually was the founder and owner of Invita Medical Center, which who now I'm the chief medical officer of as well, here in Scottsdale, Arizona. And he started sharing with me about, we met at a mutual friend's birthday party, and we just deep dived on medicine and diabetes and prevention measures and what's the latest and greatest in technology and data. And my eyes were just wide open. This is what I was hoping for. This is what I wanted. And I became a patient at Invita, shortly thereafter, and just took a deep dive on really being able to look at what is the root causes, what is the actual ability to be able to have this functional medicine approach
Yeah.
in my health and prevention. And my life hasn't been the same. At that point, I then started going into looking at what I wanted to do with medicine, and it's just been it's my life has continued to bloom, and I start to be able to look at these other opportunities. So, went into medical school, graduated with my naturopathic degree, and ended up going into practice at Invita Medical Center. To be able to treat chronic diseases and cancer. Invita was began 25 years ago, trying to be able to treat the worst of the worst conditions. How do you, when you have a technology forward, you're personalizing, giving precision therapies, and yet this is where people are dying, unfortunately, of not knowing what's going on, or they're jumping around from doctor to doctor, continually looking for answers, wanting to know what's going on. And it's a real personalized precision approach that's data forward, data focused, and technology driven. And this really this I loved this. Well, anyways, this was we've had great results with Invita, but this was also where, if it's not covered by insurance, this really just wrenched my heartstrings, because at the same time it's like, well, here we have this amazing outcomes where actually healthcare is outcome driven, and then you're literally having where the cost, it can be expensive for out of pocket. But when you compare it to the costs of traditional of like oncology, for instance, we had 2021, 2023 data, and we started looking at our data, and we were 3,500% better outcomes than the traditional one size fits all. I call it the cookbook model of chemotherapy, where if you have this stage, if this grade, this is the model that you get. There's a much better, slick way to be able to look at with data and technology, seeing are you already resistant to your chemotherapy? Are what is diet and lifestyle? How does this
Yeah.
focus and this ability to help support you on your cancer journey? What does it look like to be able to actually pair these adjuvant natural agents that are actually having biomarkers within the body, or off-label drug targets that maybe aren't a chemotherapy, but maybe are a antibiotic that has a certain mechanism that's causing a cancer to invade and grow. And this is where, when you start to put these together, this is what we've been building it off of. But we've been doing this patient-centered approach, but we did our actuarial data, third-party actuarial data, and we were half the cost. And this was just, to me, this is insane, because you have better outcomes, lower cost for just, again, better patient experience. And so for us, it was this ability to be able to say, how can we do this better? And so Solidarity was created again back when we got into Solidarity. We started actually sharing. We partnered with a community that's been sharing for since the 80s. And so Solidarity began. We started moving in this way of being able to say there's got to be a better way to take care of healthcare expenses, that are working with providers, that are focused on outcomes, that are doing this work that we're doing. And this is really where Solidarity began, to be able to say, let's do this ethically and affordably, and getting the better healthcare that's focused on providers that are actually wanting to be able to treat people across this country, and starting to work with providers to be able to do that. And we share into a lot of, again, I call it 2.0 medicine, this model of medicine where, big hospital, big pharma, we still share into this, right? Again, as a healthcare sharing organization, but where we actually see these benefits. I mean, we need we need the open heart surgery,
Yeah.
to be able to actually do the coronary artery, or the cabbage surgery. But and we share into that all the time. We still need the transplant, because the liver's failing. I had a transplant patient that got COVID. He was a father of four, had a transplant because he got COVID back during the time, and it actually triggered an autoimmune response that caused his liver to fail, an autoimmune hepatitis, and his liver began failing. And anyways, he was in acute renal failure or acute liver failure. We ended up transferring him into a hospital in Southern California, and we're able to get an amazing transplant for him at a really good cost. And our members shared into all of this, right? So this is the kind of level of where you need this system of 2.0 medicine. But this is where, what if you actually, before you need the cabbage surgery, the coronary artery bypass with graft, which is open heart, what if you're able to do it in a way that's able to actually prevent cardiovascular disease
Yeah.
from occurring? And so you run this data metrics. I just did a blog recently about, even we thought, you just go do a CT scan of the heart, and here you're getting a calcium score. But again, do you know calcium score actually isn't the best predictive measure of having a heart attack or myocardial infarction? It's actually soft plaques that actually allow for the rupture of soft plaques that actually cause a heart attack. So this is all where, if we aren't paying attention to the data and outcomes and making sure that you're able to have a precision, personalized approach to your healthcare, well, many people don't know that. And so you become lost, and you become essentially, you become crushed by the system, because this is just what you do, and it's not data driven, and it's not metric driven. And the real unfortunate thing is that too many times people are making life altering decisions on an insufficient amount of data. And this to me is inappropriate, so that's where Solidarity is really taking this ability to be able to actually enhance, to be able to say, yes, we're sharing into, with great business practices, that ability of being able to share into um, the standard model, hospitalizations, all the 2.0 care. But we also do this whole dynamic of focusing on prevention, wellness, data driven when it comes to personalized precision medicine. I was talking before this show, and I love that you're in compounding pharmacy. We actually do compounding medicines that we actually share into or reimburse our patients. We actually, directly share with some compounding pharmacies as well. I love this personalized precision approach, and you actually see lower cost, improved outcome many times, so just a little about who we are and what we're doing.
Well, that was a lot, and I appreciate it. And I so much, to dive into with all that you just went through. But I got to tell you, just going way back on the ACE inhibitor, um, and you talk about data, and there's no good data. Well, they will tell you different. The traditional system will tell you, well, the data says, and the evidence-based medicine is that, you need it. If you're a diabetic, you need an ACE inhibitor to be renal sparing, and it's going to save your kidneys. And here's one of the things. Let's just admit this, John. You can't trust most of the data that's out there. You just can't trust it, because pharmaceutical companies have completely biased the data. As a pharmacist, I don't trust most any of it.
So, just to comment on what we're kind of talking about. Traditionally, I believe doctors were in more control of the system. And what we have is MBAs and administrators, and that part, whether it's in your hospital or clinic or the insurance company. And so it's taken away that the science and the learning and being open to what is actually happening in the clinical setting. Because doctors now are restricted to how many patients they are seeing, their paperwork. What your outcome is how you prescribe according to the logarithms or the standard of care that is being dictated by somebody who is not really studying the science anymore. Because when we were at the end of our career of going to school as being a student, there were still what we called round tables, where doctors were actually communicating together on a personal level as to what was happening, what's the new treatments, and how it was working. But we've kind of closed that door on them. So this is exciting that we're getting back to what is working over here might work for my patient. And most of the time it's modalities that aren't extreme. It's just that we aren't opening our mind to it and saying this is a possibility. And currently what's happened, at least in the last few years, that we've seen with people is that if a patient does ask, they're even shut down. They're like told, no, that's not a possibility.
Yeah, Janet, you're hitting on a couple of things. I mean, because you see this, and I've actually seen that, even with the trajectory of how data is currently being, all the research, even good research that's
Yep.
out there, and data that's being given. And I do agree that you have to really be very, very discerning in how you're reading the research, because you're right. It is not always as clear or pristine or without conflict as
Right.
many people would think. Um, and so you're right about that, but also when you start to see that the data that's out here is moving so quickly that you're able to see that again, well, we live in the information age, right? I mean, we're all these cell phones are rapidly advancing, and yet why does it feel like our healthcare and the outcomes? It's like, why am I not? Why am I not seeing this? Where is this actual? Where are these doctors? Where are these results? Where is this actual ability of seeing those outcomes? Who is actually implementing the work to be able to deliver some of this actual truly evidence-based medicine? And I use that tongue in cheek because again, I think this evidence-based, I'm a huge fan of evidence-based, and yet what we actually are seeing out there is not so much evidence-based. Let me give you an example of this.
No, it's not.
Okay. So we see, I have expertise in genetics, in transcriptomics, and specifically looking at this to be able to design programs around for cancer, right? And what is we see, the advancement of technology. There's technology now that exists. It's called one of the markers that we run. It's called cell-free DNA, and this is similar to, say, for instance, if you are many times more people know this in the world of obstetrics now, when you have a baby, that you can run the blood of a mom and you can run the blood of the mom and know exactly the full genome of the baby, right? This is technology that exists now. And we use that similar technology in oncology and in cancer, where you can actually run the blood of the patient and know the genes that are mutated in the actual cancer. It's beautiful. It's absolutely wonderful to be able. It's called a liquid biopsy. It's great technology. What we actually find, though, is that in 90% of our patients, they are on being prescribed one or multiple drugs that are already resistant to the cancer. But again, your oncologist will be able to just run a test where they don't run the test. Many
No.
times insurances don't cover that test. And I always say, if you're an oncologist, you don't want to be telling your patient I always like to say docs they do what they get paid for. Unfortunately, the hospital system does what
Sure.
they get paid, what we get paid for. And it's usually doctors that are genuinely wanting to do good, and then they go into a system that is not having true incentives, and so it doesn't actually incentivize outcomes. But what you start to see is that a doctor doesn't want to run this on a patient if they know that it's going to be if there's resistance if one or multiple drugs. And so this is where it's a very difficult conversation to say, well, if you have a stage 4 colorectal patient, and you're saying, well, one of those drugs that I'm going to give you because this is the standard of care is resistant, well, I'm still going to move forward with this because this is what your insurance company is going to cover.
Yeah.
This is what I have to do. It's this square peg in a round hole, unfortunately, and it's not common sense. It's not evidence driven. And this is why, again, even saying, hold off, what we do is say, let's actually put the doctor and patient in charge. And let's actually make sure that we're driving it by data. And it's not a bureaucrat or a standard of care model that's saying this is what you have to do in order to get paid for it. And this is where you start to open up the ability to say, actually, these protocols that we've developed over the last 25 years based upon data, real life outcomes, are now able to say, well, actually, instead of that medication, I'm going to pair it with this medication. And then maybe there's other targets that, like I was sharing about this, you can have a drug like doxycycline that hits this pathway called MMP. This is a metalloproteinase. This is essentially it's a way that cancer likes to invade into tissue, and it allows for metastases to spread. Okay, there's not a chemotherapy that actually targets that. And this is
Right.
where you want, but you can pair it with your other chemotherapeutic agents to where now it actually silences that ability of that metalloproteinase, if it's there, to be able to allow for that cancer to be able to keep invading and spreading. So this is where you start to develop these processes based upon data. And this is evidence-based, you know?
Right.
This is
Yeah.
where you're able to see the results, and that's very exciting for me, because you start to be able to evaluate based upon a
Mhm.
patient and the individualized outcome. I give this same example. We love talking about carcinogens in our society. I love it. We need to be raising awareness on environmental toxicology and carcinogens, or these various endocrine disruptors, because this is really having a huge issue. I love that we're combating these dyes in our foods. These things, these petroleum dyes are just awful. They're in our pharmaceuticals as well, you know, in our pharmaceuticals and the capsules. This is where they're everywhere, it feels like, in our foods. But these are causing some severe issues. You know, I give this clear example that even in the state of California, you have to be able, as a business, you have to label if you have known carcinogens and your potential exposure to your clients, you know? So you go to Starbucks and, you actually have it labeled, oh, there's a known carcinogen or a possible carcinogen in this environment, right? I'm like, okay, that's helpful. But when you actually then come down with cancer, even if it's a stage 1 breast cancer, right? You get a lumpectomy. Well, who's the one that's actually saying, wait, let's actually do a history. Let's actually evaluate, where did this come from? Why did you start
Yeah.
to just develop this actual breast cancer? And there's many reasons why. Carcinogens are one of those, though. Herbicides and pesticides that we're exposed to are carcinogenic. Phthalates, things in our toxins in our beauty products or cleaning products, are carcinogenic. So when we look at, again, we do an environmental toxicology history, be able to look at this, do a full history, and then we run tests accordingly. When you find something that's in a 95th percentile of a carcinogen in the patient's bloodstream or urine, we know that this is actually okay. We found something here. This needs to be cleared, because why are we continually treating cancer? Yes, we do genetic targets, but why are we doing this and continuing to be able to not remove the gasoline from the forest fire? And this
Exactly.
is again, this
Yeah.
is where, when I look at this and I start to say, well, an insurance company is not going to cover that toxicology testing.
Mhm.
And then you have questions by a patient to say, well, doc, can you do this? And an oncologist, because they're not trained in this, or this is not the training of an ordinary resident or a fellowship in oncology. Then you're left with a patient that's concerned about this because it's common sense. It's logical. They're reading a paper talking about how these carcinogens are actually could be the root cause of a breast cancer. And you look like, again, dumbfounded, and almost act to be dumb, because this is, as a patient, because you are being told, well, I'm going to go ahead and that doesn't exist. Don't
Right.
worry about that. And
Yeah.
and I feel like
Right.
it's almost this gaslighting of a patient to be able to say, I'm just asking good questions. I want to be a good advocate for myself. Is this
Mhm.
out there? And that's what I always tell patients. Be an advocate for yourself, because you're more intelligent than you think you are. And you want to make sure that you're asking questions. And if something's not feeling right, ask the questions, because you should have a doctor that loves to accept questions. I mean,
Right.
I'm a researcher but I love research. I'm inquisitive. I want to know what is going on so that we actually can have those answers. I don't know everything. I certainly don't claim to know everything, but I do know that when it comes to that ability of seeking and finding those answers and looking for data behind it, it becomes illuminating of what we actually
Yeah.
see. So cancer is one of those areas. Chronic diseases, autoimmune, neurodegenerative, dementia, Alzheimer's. It's another dynamic. What's actually the root cause? I love that fibromyalgia is, pain in all four quadrants, and yet nobody really knows what's the actual root cause of fibromyalgia. And when you start testing, then you can actually see, where are these potential toxins, these hormone endocrine disruptors, seeing infections, chronic viral, right? Again, Epstein-Barr virus, these other chronic viral infections that can be correlated. This is where, when you start to see these levels, Now you can start having a treatment plan to be able to treat it. I'll share. I know you guys probably know the story too. Fibromyalgia wasn't a diagnosis when I first came onto medicine, right?
No, no,
It
30 years
wasn't a
ago.
diagnosis. What was the treatment for it? It was that you had to be referred to a psychiatrist because it was in
Exactly.
your head. Okay,
Mhm.
when did fibromyalgia finally? What kickstarted the process of actually having a ICD-10 diagnosis for fibromyalgia? It
Mm,
was when there was a convenient drug that started coming on the market and being done in research called Lyrica.
Right.
Lyrica was the drug that was finally approved for fibromyalgia, but this was not generally accepted into the actual mainstream medical system until there was a drug that was finally able to be prescribed for it. Very expensive, and yet it doesn't do anything to do with looking at why do you have
no,
pain in all four
Mhm.
quadrants?
right.
What's going on with the system? Why are we anxious? Why are we not sleeping? And so this is where when you start to actually unravel and unpack, Janet, like you were saying, sometimes these things are just, they're not as difficult as we actually make them out to be. We're just not looking at this. What is your nutrient status of magnesium? How is your sleep habits? Are we actually on screen time? You know, that
Yep.
these blue lights that continue to excite our brains that don't allow our sleep. What's the relationship like with your significant other? Have you had forgiveness? All of these dynamics that are then playing a role in our mental health, our anxiety. What's the GI tract doing with the ability of having microbiome health that is signaling potentially these other issues with anxiety and depression? How
Right.
is our diets? Are we even exercising? Are we getting out, creating natural endorphins, just moving? So if exercise if exercise was a drug, it would be the very best
I
blockbuster
agree.
cancer drug. It would be the
I
blockbuster
agree.
cancer drug, but it's not being
Well, not
done, and
only
it's not
that, but
even being recommended.
no,
And
No.
so you
yeah,
see this therapeutic fasting is a beautiful thing. This intermittent fasting. So these
Yep.
diets that actually can augment the outcomes of
Exactly.
your of and I also say this too because this is delicate. When you are if you've got, say, for instance, a stage 4 pancreatic cancer patient, you can't just do heavy fats because your body's having a hard time metabolizing fat.
Exactly.
So maybe a ketogenic diet isn't good for you, but there's other ways to be able to get around, to be able to look at what's the metabolism going on in the body. So you
Mhm.
can start to design a plan, diet, lifestyle, direct, good targeted chemotherapies, other direct targeted treatments or immunotherapies that are going on to be able to actually start to unpack and start to drive a system to be pro health and not pro disease.
yeah,
And that's not just this quick, pill for every ill fix either, and
Right.
this is why it's not just a quick response. This disease usually is taken, many chronic diseases have taken, 5, 10, maybe 20 years to finally build and grow and start to develop. It doesn't just happen overnight. It takes changes to be able to shift, but this is where it's really exciting for me as well to be able to be working on the preventative wellness end, to be able to even educate and catch and allow people to actually catch these diseases that are already showing these biomarkers that are starting to shift,
Mhm.
where we've been doing it on the advanced disease end. How being able to focus on these earlier catches to be able to say, let's be data driven. Oh, I think I'm thumbs up. I'm tagging thumbs up there. But let's be data driven on the front end so
Right.
that way we can actually make wise decisions for ourselves, because there's not just this one size fits all. I mean, that's the interesting thing. Even with wellness, you don't know until you start to actually do a little bit of testing. Like, why am I feeling that I'm fatigued? I love going to the general primary care. I'll just come out swinging today because I just there's so many dynamics. You go to see a general primary care doc. I love this. They're like, well, you've got hypertension and you've got high blood pressure, or you have high cholesterol. So let me just otherwise everything else looks pretty good. Shawn, everything else looks pretty good. But let me write you a prescription for simvastatin, which again, even cholesterol, if you actually look at the data, is actually not
no,
it's loosely correlated with coronary artery disease. but it's loosely correlated.
I would say very loosely.
There's other mechanisms that are actually that you can actually identify and look at to be able to make sure that you are truly at risk. I mean, or LP little a, ApoB, all these different and inflammatory markers. Again, these are all dynamics where if you are concerned, you really should investigate, because coronary artery disease is a real issue. And some patients do benefit with a simvastatin or a statin medication. You need to take, obviously, a CoQ10 with it, but very small fraction of the population, I believe, that actually needs this. But when you actually start to look at this, you start to see that, again, when you go to see that primary care, that's all they're writing for. And then they're, okay, I'll see you next year. And then you're left with, again, thinking, well, hold on. I'm having a hard time sleeping. I'm having fatigue. I'm gaining weight and I don't understand why. My brain isn't functioning like it used to in my 20s. My libido's low. I'm going to a doc to try to see cancers, and they're just telling me, well, here's a cholesterol lowering medication and a hypertensive medication, and here, I'll see you next year. And I think, hold on, this is why we have an opportunity to be able to catch these diseases. And actually, not just, I think about this from a standpoint too of, we can't just keep selling, oh, well, let's just give you on a diabetes medication to be able to treat the diabetes. It's saying, hold on, what's happening with a diabetic, a type 2 diabetic, when they're going through metabolic inflexibility, insulin resistance? You have a risk for dementia. Your mind isn't thinking the way that it used to. You're fatigued and you want to sleep after a meal. And yet your doctor isn't actually saying, well, Shawn, do you actually want to feel better? Do you want to
Right.
actually have a libido? Do you actually want to make sure that you're able to actually have energy and you're sleeping well and you're not anxious and you can actually make sure that you can get to the gym? So this is where, and it's so interesting because we downward spiral, never even looking at these root causes. What's your alcohol intake? Because guess what? That alcohol is going to continue to be able to cause further disease. And this is going to start to be able to actually create more of a worsening problem. And now you're addicted to your alcohol and you're never even addressing this in your consult. And this is what's literally causing this continued weight gain, calories, and this downward spiral. So or stealing your testosterone, your estrogens,
Yep.
these men then you're gaining weight and the testosterones are tanking because the actual testosterone is converted by the fat into estrogens. And now you're having all of this downward spiral that continues to just propagate. And you don't have I feel like, where's the adult in the room saying, I got an answer for you? Because the data's out there, the evidence is out there, and it's amazing. And the patient can actually thrive. But I don't know. I feel like I'm a lone voice oftentimes, but I love talking to docs and I love talking to people because it's like we have a system that's broken in healthcare. And I am dead set on making sure that the system works for patients, that the
Right.
system, and this is where health sharing is a big part of this, because this is why I'm going to go back to Janet. You're absolutely right. I've talked to so many executives at Blue Cross Blue Shield, Aetna, United, all the biggie insurance companies, big hospital systems. I like to say this with insurance, no offense to insurance. I'll say this though. If you look at the people that are running insurance companies, who is their fiduciary? Who do they have responsibility for?
They're shareholders.
It's shareholders. And it
Exactly.
is not patients.
Not even
And this is
maybe.
the real tragedy that goes on. If you actually are seeing, again, another thing that I love to talk about to just start to raise awareness. When you are getting referred to, if you're going to see a primary care and you're getting referred to a cardiologist, could you need a cardiothoracic surgery, or you need something, evaluation of the heart? Well, how do you know? How is the doctor making that referral to the cardiologist? How is the doctor making the referral to the cardiologist?
It's
Well,
not the best
I'm in
doctor.
medicine. What's that?
It's not the best doctor. It's just because they're
It's
in
not
network.
based upon data. You
No.
want to know what it's based upon? And this is just real world. It's usually based upon, well, he belongs to my healthcare system, my big healthcare
Yep.
conglomerate. And so I'm going to just send him to my healthcare conglomerate, not oftentimes based upon the data of the best, or I've gone to school with them. I went to medical school with him or
Yep.
her. Does that make him the best doctor?
Nope.
No, or he's my neighbor. And so, or I've always done it. This is just my practice. This is who we refer to it. I went through the system and I became a young doc. I came practicing here with my partners. They referred to him. So I just continue to be able to do it. Nothing is actually, or we as patients, what do? We're saying, okay, let me Google this doctor.
Yep.
Let me Google this cardiologist. And guess what? You're looking at Google reviews. Oh, this doctor has really good front desk staff. They look really kind. Guys, this is not based upon data. Okay.
Right.
This is where you want to be able to see what is the actual reinfection rates? What is
Mhm.
their procedures? How many procedures are you doing? If you go to see a
Yep.
cardiothoracic surgeon that's only doing a handful of procedures every month,
Mhm.
guys, they're usually costing a lot, and I see the finances behind this, charging a whole lot and actually have higher complication rates.
Mhm.
But if you see a cardiothoracic surgeon that's doing these procedures and has got this system and is doing it well, guess what? They're usually actually, and you actually see the data of reinfections, outcomes, not coming back to the hospital, low mortality. You start to see that these docs are usually the ones that are doing it on a regular basis, that actually have a system. They're the ones that are having great effect. I always like to say, kind of tongue in cheek as well, like, you don't want me doing the actual, we have a procedure where we take a catheter the size of your hair and directly target the tumor and develop those genetically targeted medications. We call it CIPI, chemotherapy immunotherapy precision injections. It directly injects. You want my surgeon, my interventional radiologist doing that, who's doing it all the time. You don't want me
Right.
doing it. I can charge a lot for it. You don't want me doing it. And so this
Right.
is the whole point, is that you want to be able to look at data to make decisions off of. You don't want to just keep going along with your blinders on, with blind trust that is actually, this is not evidence based. There's huge issues with this. And so this is where you need systems to be able to help you, because without knowledge, I always like to say again in the Bible, with lack of knowledge my people perish. And
Right.
lack of knowledge, you start to be able to have, again, real life issues that you start to see. People are, it's not just a change in decision. You're seeing life altering decisions based upon who we go see, what tests they're running, going around from patient to doctor, continually increasing cost, and yet nobody's saying, what's going on with this autoimmune condition? What's going on with this? Why are we having neurodegenerative? What's going on with, why are we having um, um, movement disorders? What's going on with this? Again, or going to see a mental health counselor. There was just a recent, we've seen COVID just increase these mental health visits. There was an article recently published about pediatrics being treated with mental health in the ERs. And this is just tragedy to me. ER is not the place you treat mental health.
No.
And yet, this is where we're seeing it. And what is this doing? It's increasing cost, really not doing anything for outcomes. And so, this is where, when we're able to actually get in front of problems and helping support families and patients and members to be able to say, hold on, let's get better outcomes. Let's starting to direct. Let's actually work with you to be able to find providers in your local area and start to be able to actually do this, where we're actually shifting and supporting the ability of being able to get well. It becomes an exciting thing. And no, it's not easy. I feel like I'm climbing big mountains every single day. I'm climbing Everest right now, and I'm only at the
Yeah.
base camp. But at the
Right.
same time, it's this dynamic of like, it's worth it and it's exciting and it's awesome, because you see patients that actually get the responses from this. It's just
Right.
beautiful to be able to see.
Well, it empowers people to make decisions when they are given that information. And that's the one thing Shawn and I have really liked about um, health sharing, is that you're not locked in. You're not locked into just one size fits all, or that square and circle that you were talking about. That there's options, and that puts you in the driver's seat. So if you have an insurance company, they're in the driver's seat, and they're in the driver's seat of your physician or your oncologist or everything. And we've touched on that. So tell us a little bit about how you are freeing your members in a way that they can take it, not only just because I really strongly believe when we are bankrupting our patients, that's harming. It's really against the oath of Hippocratic oath, that is part of harming. And then not treating them in a way that's beneficial or giving them the best options, I believe is harming them too, because we're just putting blinders on. So tell us how this is so much different for people in the financial part.
Yeah, so I mean, even something so we just see year over year, because of these interests of big insurance, big hospital, big pharma, these costs just continue to escalate, right? And so this is where one of the things we do is, even if you need this emergency surgery again, and you're at a hospital system that's, having huge costs, 500, 600% of Medicare costs. I mean, just astronomical. Give this example. I had a case of nasal polyp surgery. It was a couple years ago. Nasal polyp surgery. Hospital and doctor wanted to be able to charge $96,000 for just a removal of a nasal polyp. Okay. I'm like,
Wow.
this came across my desk. I said, this is not going to happen. We need to hold on. We need to be able to actually direct. We were able to get to a provider in the same zip code, literally different provider, different hospital, where the actual procedure, any guess for this actual procedure, what the actual cost of this
I'm gonna
was?
guess 5 grand. 5 grand.
Oh, and Shawn, you're so close. 6 grand. Six
Wow.
grand for this actual total procedure.
It-
So this is
it's
where
a
when you
scam.
start to say, and guess what? It's fraudulent. And it happens
I mean,
because
imagine
there's
this,
lack
John.
of
Sorry,
transparency. Yeah,
I get
go ahead.
passionate about this, but imagine this, John. Imagine in the same zip code, if on on one area of town, there's the same exact car that is 20-fold less expensive. We wouldn't accept it, but yet in healthcare we accept it, and we shouldn't.
That's right. Well, and because there's been blind trust.
Yeah.
Yes.
And then you have almost there's think about this, is that it's almost these third parties, that like an insurance
Mhm.
company, that we think, well, they have our best intention in mind. They actually they have the best intention. I'll say this, that as well, when you actually start to see that this idea of an insurance company, that it's really starting to support their stakeholders, their shareholders, not their actual patients. You start to see this again. I always like to say, whatever your thoughts are about the Affordable Care Act, I always like to say it's been about the Unaffordable Care Act. And
Right.
there was an intention that I think was well desired in the Affordable Care Act. And basically what this says is that, 20% of your premium can go towards profitability from an insurance company.
Right.
80% has to go towards your claims, your actual medical care. Okay. This was fine because you started seeing insurance companies essentially have, before the Affordable Care Act, were taking a whole lot more profitability, which isn't good either, right?
Percent wise.
Right.
Percent wise. But what happens with shareholders if you're restricted about how much of your premium goes towards profit and your admin costs and your profitability? Well, the only way for you to continue to be able to increase your profitability is to what? Increase your premium,
Right.
because now 20% of a bigger premium is, well, it's a bigger number. And so this was really, again, when you start to see, it's really interesting. I have graphs where you start to look at the stock prices from, I wish I would have known this back in 2010. I'd be doing so well. But again, I learned this, not too long ago. Again, this was about 5 years ago when I started really doing a deep dive on this. But you see this tear. It's doing better than the S&P 500, all of these
Mhm.
insurance companies, and yet their premiums continue to go up. We see
Yeah.
this continual escalation of premiums year after year after year. People are continually getting sicker year after year after
Yep.
year. Cancer rates of diagnosis for even younger populations, less than 50, continue to rise year after year after year. All of these dynamics that we're seeing, and yet nobody's actually shifting these problems. I give this example. I'll go pharmacy. Okay, so there's a medication. Again, some of these high cost drug medications. And well, I'll say there's really no incentive from an insurance company to start lowering cost. That's the issue. You start to see that they're looking at pharmaceuticals, right? How do pharmaceuticals work with PBMs? The administration just passed an executive order. I think it's a great executive order, trying to be able to actually bring costs lower for pharmaceuticals, right? But where this is at, we're seeing that this ability of saying, here we have this um, of these pharmaceuticals, some of these high cost medications like Skyrizi or Stelara. Stelara is a medication that suppresses the immune system. Okay. Oh, I gave another thumbs up. It's my auto thumbs up. Uh, Stelara, though, what is it doing? It suppresses the immune system because it's given for autoimmune conditions. So I had a case of somebody that was on that had psoriatic arthritis, which is an autoimmune condition causing psoriasis, but it also creates joint pain. And so you suppress the immune system with this drug. This medication is costing 25 grand a month. And this is where this medication is 25 grand a month. When you start to say, hold on, what is actually the root cause of this medication? Now, there's some
Exactly.
international sourcing pharmacies that can drive that cost down. There's some ways to be able to help support those costs, but it's usually this ability of, again, a PBM getting a kickback from the actual the pharmaceutical company that you're still and the insurance that's driving that actual cost. When you start to actually look at this, and this is a case, psoriatic arthritis, there's actually root causes to why the body's autoimmune condition starts to create the psoriatic arthritis. And when you start to identify this, now you can actually say, let's run some tests, let's evaluate. Now instead of 25,000 a month, this is $800 a month
Exactly.
to be able to actually go through the work. And guess what? You feel better. And you don't have the side effects of Stelara. What is the side effect of Stelara? Well, again, because it suppresses the immune system, there's actually a huge risk of sepsis. Because when you have an infection, your body doesn't mount an
Yep.
immunological response to it. That's why
Right.
they're like, if you have TB, tuberculosis, don't go on this medication, right? Again, so there's these risks. But then if you have sepsis, then you're having risk of hospitalization, more cost, worse outcomes, and we begin this track. I always say, okay, the other thing is another risk of these immune suppressive medications is cancer. And so this
Right.
is where again, so you start to develop this downward spiral instead of saying, hold on, what's the reason that you actually have this disease process in the first place? Let's do some investigation and testing. And now, again, I'm all about improving outcomes because patients are worth it. And at the same time, you can reduce cost. It's simple, right?
Right.
Yeah,
Well, it should
another
be.
example where I love this, right, too. If you are going for mitral valve prolapse, I love this, right? And instead of doing an actual full open heart surgery and replacing a mitral valve with a pig valve, that's still being done. This is still your standard of care, in the current industry. Go through the amount of hospital time, recovery time,
Uh-huh.
absolutely happens. I always like to say, well, there's an actual interventional radiology procedure where you go in with a catheter through the actual groin. It's an artery through the groin, the femoral artery. You go on up to that actual mitral valve, you place clips in the mitral valve to be able to repair the mitral valve, and then you're out through the actual that artery, and then you put a band-aid right over the place where that catheter was inserted. Guess what? The recovery on that, you're out of the hospital the next day. You don't need
Wow.
physical therapy. You're out and you're actually this is the whole dynamic, and guess what? The overall costs are lower. But if you don't have somebody directing and knowledgeable about this, I give one more example, and I love giving this example. I like to talk about carpal tunnel syndrome, right? Carpal tunnel. What's the standard of care for carpal tunnel? Again, standard of care is actually cutting open it's when it's when the ligament is constricting the median nerve, so it's causing weakness and pain in the actual hand. Okay, standard of care is it on your insurance plan that they're just going to say, yep, you're covered for this, is cut the actual skin open, cut the ligament open, release the actual nerve, and then sew up the skin to be able to actually improve the condition. Recovery is awful. You actually have to go through anesthesia. The recovery from anesthesia, especially if you're sensitive to anesthesia, is difficult. Anyways, it's a difficult recovery. Okay, what if I said you could actually fight the insurance company and actually have an appeal? And this is where you could go in laparoscopically on this to be able to go in through laparoscopic. It costs more, but you can say, hold on, I use my hand for work. So I need this hand, and it's on my dominant hand. I'm right-handed, it's on my right-hand side. So I need this. And insurance company says, okay, sure, we can actually do this. You can go in with laparoscopic and actually cut the ligament open. It's much better, but the recovery time is still significant. What if I said that there's a different procedure? This procedure is using a thread therapy where you do interventional radiology with an ultrasound. Ultrasound, you actually are taking a needle and you bring it in the skin, under the skin, but above the ligament, and come out the other side. Thread that needle, take the needle out, you keep the thread in, you take a different needle, you put it through the same hole, and you bring it underneath the ligament and out the same hole. And then you take that thread and you thread it through that needle. And then you take the needle out. And then you take that thread and you just cut the ligament. And then you take the thread out and you have two little holes and you put a band-aid over it. It's localized anesthesia. You're back to work the same day.
Wow.
Okay,
Wow.
this is where we have become, and I say this, you don't need, oh my gosh, let's run a double-blind placebo-controlled study to be able to say that's better than
Yeah.
the standard of care model that's increasing costs and reduces outcomes. It's better. It's
Yeah.
amazing. The results speak for themselves. This is where when you start to have somebody that's knowledgeable in a place to say, this is what we're doing. This is innovation. This is using the best of technology. And guess what? We share into this. We've created customized codes to be able to make sure that these are eligible. Because that's the other thing, is that if you're restricted to a code, ICD-10 code, like fibromyalgia, and your CPT code, you're playing by the rules of a square peg in a round hole.
Yeah.
Mhm.
I can't do it. I can't do it. I'll never be able to get that better treatment. It's always out of reach. And it's because you don't have the system that's been able to integrate into the actual beneficial treatment. And so that's why, again, at least for me, I mean, I think I'm always scouring. What's the best? What's the best? Where's the data? Where's the data? We live in an information age where it's always coming, and it's so brilliant to see this technology forward. But if you're left in an antiquated model where you're a peg in, or a cog in the wheel of a system, it's hard to break free. And it's, it's the craziest thing when you see it, when you're able to live in this dynamic, when you see this model, you can't unsee it. I feel
Right.
like I live in the
Right.
Matrix. I'm like, I can't go
Yeah.
back. I can't
Right.
go
So
back.
true.
It's immoral for me to
Right.
feel like I have to
I
go
agree.
back into a system to keep fighting. And it's difficult because there's a lot of pressure on patients that they feel when they're in that system.
Yes.
And it's like, oh, I feel like I've got to just keep blindly following. And then it's like, hold on, you've got to be able to be an advocate. You've got to look, you've got to ask the right questions, find docs and professionals that are going to give you these right answers. And then this starts to be able to develop this journey. And you start to see that, wait, there's a whole new level of medicine that's out there that I never knew about. And that's really where, again, raising awareness, being able to actually come on, discussing these things and having a system that's built that really allows this to be taken place in an effective way, instead of just being stuck in a cog in a wheel, and then we just are lacking options and we're paying huge premiums.
Yeah.
Shareholders are doing just fine, but there's, we're left with, we're continually getting sicker, we're continually being, having higher deductibles and not actually getting this ability of, being able to get well and keeping our finances under control, so.
Exactly. Well, so I love it, and we have a listener viewer, Sabrina Gonder, says, "I love this model." So John, and as we wrap this podcast up, in a few sentences, explain how, for those that don't understand or know, explain how a health share works. You already talked about how Solidarity can advocate for patients on different care options, but tell us financially how health shares work.
Yeah, so essentially, a health share is a company that allows members to share with other members. So instead of this model of an insurance where it's creating a pooling of all the funds, and the funds are the big insurance company's funds. You give your funds, your premium, to an insurance company, they pool it, and then they're the ones dictating where it goes and what happens with it. a healthcare sharing ministry is such that you have members that are facilitating, we facilitate other members cost sharing. And so what this essentially means is that it's a way to pay for those health expenses, but in a way that's able to say, we actually at Solidarity, there's all different types of models at it through healthcare sharing. But what we've done is we actually have individual bank accounts that each member has that are individual members, and we've developed a whole process to be able to have when a bill comes on in, and we work with the current billing system. So you can, as a provider, bill us directly using EDI, and we use the best in technology and in billing practices. And then what it does is that it takes the members' accounts that they've agreed to be able to actually say, okay, these dollars in these accounts are going to go to share with this member to be able to share those medical expenses. And so every year it's not this, well, I need to be able to, pool my funds, restrict these dollars from going on out, and then having another insurance company on top of that that's telling me what I can and cannot do. And it's called a reinsurance. And then another insurance company on top of that that's telling me I can't do that. This is the way the current insurance model works, where we're able to say is actually say, you know what, our members and are it's a community of people that believe that there's a better way to do healthcare, and this is what we've agreed to, and it's moral and ethical and affordable, and we're able to actually start to be able to say, here's when these dollars come in these accounts, when this bill comes on in, we're able to actually pay the provider. Either it works very seamlessly with we call it a explanation of sharing, where it goes to pay the provider. If you actually have paid out of pocket for it and need reimbursement, you submit the forms, and then we actually reimburse the members. So again, there's a whole system behind it, but it's built on a really beautiful infrastructure that's able to actually make sure that those sharing dollars, one, are that there's not a fraudulent action either. These accounts, they can't be touched. These go towards the sharing dollars of the members. And this is where there's all programming that's a part of this. So this is where, for us too, the accounting principles have to be high. And sometimes healthcare sharing has gotten a bad rap because of its inability of having maybe the standardized processes. And so some healthcare sharing ministries have had a black eye in the past as far as this goes. And I always like to say it's good to have really good processes behind what you're doing, because this becomes now a model that's able to start to be able to really, really fix and be a part of the solution of
I,
this
I, I
medical
agree.
insurance complex that we're fighting against.
I agree 100%. I wrote a book about it called Sickened: How the Government Ruined Healthcare and How to Fix It. And there's a 6-step solution in there. And one of the solutions is health shares. People need to start using health shares more. So, John, you talk about affordability. Tell us how much more affordable. Well, I guess tell us what the price is for health share for Solidarity Health Shares.
Well, we have all different pricing. One, if there's no question. Oh, let me see. I have having a call come on through, actually. Oh, there we are. Yeah, so one of the things that we always like to say is that you can go on our website, check out the actual price. It's always going to be very competitive as far as this goes. There's different models, though, that we have as far as all the different levels of the different programs and the different levels, depending upon, we call it a annual unshared amount. This is going to be your, it's similar to a deductible. It's a little different because it's a healthcare sharing ministry, but people can think about it in that way, and you can graduate up. So we have programs that are really consistent with all the different people that are looking. Like I said, again, it's usually much more affordable than your traditional health insurance as far as this goes, and can be a really great way to be able to really have this kind of care, these options to be able to actually support you and your family.
Well, I will tell you, John, Janet and I have a health share, and we have since over 10 years now, and probably 10, 12 years. And we have saved, this is no lie, we have saved on premiums, monthly premiums. We have saved over those years, probably over $200,000 on monthly premiums.
And
It's
I
hard for
believe
some,
that. I
yeah,
believe that. And so I
which I,
100%, you see this, right? I've had stories about people that are saying, they had insurance, they were paying their own premiums, and they couldn't afford a home. Once they switched to Solidarity, they were able to actually, this
Yeah.
was a young couple. They were like, I'm
Yeah.
finally able to actually, afford my mortgage as a result of this ability of being able to switch. And, so there's just stories after stories of
Yeah.
that. It really is where this insurance model is just, it's unsustainable the
It
way
is.
that
It is.
currently we're having insurance, so.
And not just that it's more affordable, but also we get to choose
Yeah.
where we want to go for a doctor, for treatments. Some insurance company doesn't tell us where we can go.
There's no
That-
networks. We
no,
don't have networks.
that's right.
We do have communities of preferred providers that
Yeah,
work directly with us that are awesome providers doing amazing work all across the country. But again, there's not a network to say you have to go to see this, or then if you don't see this guy in the network, then this is going to be somebody that is, then you're paying an arm and a leg to be able to go out of network, right? That doesn't
exactly.
exist in this model, and it really does. It allows that doctor-patient relationship to really thrive, and you make those decisions. I feel this moral responsibility with me, though, to be able to say, let's make sure we're getting good education, to be able to make sure that we're driving and allowing members to know where these providers are or what these options are in healthcare, because obviously it can be life-saving when you do.
Absolutely, absolutely. Well, I love it, John. We could talk forever. We got so many things in common and so many different ways of things we could talk about. You've helped us realize our goal today, which is to educate and empower individuals to take charge of their own health. And part of that is financially. I think ultimately patients need to be responsible financially for their own health. And if we have a consumer driving that, costs will go down, service will go up, and quality will go up. And health shares are a part of that solution. So thank you so much, John, for helping us realize this goal.
No, you're welcome, Shawn and Janet. Thanks for having me.
Yeah. And if you can hang on after the podcast, I want to chat with you really quick off air. So thank you, listeners and viewers, for tuning in to Health Solutions with Shawn and Janet Needham. Tune into our regularly scheduled podcast, 12:30 to 1:30 Pacific Standard Time, Monday. Thank you so much.